Okay, folks, so let's get back. Okay, the slide is over here about the thyroid hormone. Please remember, thyroid gland location, hormones, I said earlier, and how this thyroid gland is stimulated. We need the help of thyroid stimulating hormone. Period. Thyroid stimulating hormone from the anterior pituitary is needed to stimulate the thyroid gland for the production of T3 and T4. T3 and T4, please. T3 and T4. Now, in order to produce T3, T4, thyroid gland need an electrolyte by the name called what? In order to produce T3, T4 from the thyroid gland is craving for what? That electrolyte?
Calcium.
What?
Calcium?
Aldosterone. Aldosterone.
I'm not getting good nutrition.
Iron.
Iodine. Iodine. Without iodine, this thyroid gland is not going to produce T3, T4. Please remember iodine. That's why we do have table salt. If you look at the table salt, it's iodine, table salt. That means sodium chloride added with iodine to prevent this thing to happen to my thyroid gland. Otherwise, if they don't have enough iodine, this gland enlarge. That is called what?
Hyperthyroidism.
Hyperthyroidism, but that gland, enlarged gland is called what? Goiter. Goiter. Look at that. I didn't provide enough iodine to that gland, and the gland said, I'm going to help, but I have to increase my size. Goiter, goiter, goiter. Everybody's clear with that one? Goiter. And also I mentioned about the cretinism by birth defect of the thyroid gland. Is that correct? By birth defect of the thyroid gland called cretinism in newborn. Now, the major functions in this slide, it says increases metabolism and protein synthesis, overall body metabolism. Take care of my protein, take care of my carbohydrate, take care of my fat. All are controlled, regulated by thyroid hormone. Of course, we do have steroid hormone also doing the same job, but thyroid hormone also regulates overall body metabolism. My BMR, basal metabolic rate. Basal, please pay attention. Basal metabolic rate is regulated by thyroid hormone. Now, the next one, it says it influences the thyroid hormone, it influences the growth and development in children. If you remember, I said earlier that this T3, T4 normal physical growth, is that correct? That's what I said. I'm not going to change. Physical growth, mental growth, and reproductive growth. That is my T3, T4. That's what it says over here. Mental development and attainment of sexual maturity is the third one. Reproductive growth. Mental growth and physical growth. Make sure to add all those information. And also I said, it regulates my basal DMR, basal metabolic rate, is regulated by T3, T4, or I can say thyroid hormone. Thyroid hormone is transported in the blood. There are three major thyroid binding proteins which transport by thyroid hormone. Number one, 70% is taken care by means of globulin. We call thyroid hormone binding to globulin, 70%. We do have pre-albumin, and then we do have albumin also. Globulin takes care of the maximum, and then pre-albumin followed by albumin. Please highlight and remember, measure used to diagnose thyroid disorder. So we do use those, check all those numbers. Especially, please remember the number T3, T4, T3, T4, and thyroid stimulating hormone. We do have resin uptake, assessment of the thyroid autoantibodies, radioactive iodine, thyroid scan, ultrasonography, CT, and MRI scans, and the fine needle aspiration biopsy of the thyroid nodule. If the hypofunction of the thyroid gland takes place, T3, T4, serum T3, T4 will be increased or decreased. It decreases when hypofunction of the thyroid gland itself. I said hypofunction. T3, T4 will be lowered, and TSH will be increased. Is it clear? Now, so we have to know TSH is coming from my thyroid, from the pituitary gland. Now, the conditions over here, hypothyroidism and hyperthyroidism. Please remember all the features: patient with hypothyroidism present, patient with hypothyroidism present. The normal function of the thyroid hormone, metabolism. That's a normal function. Now look at that one. In hypothyroidism, decrease metabolic rate, metabolism way down. Temperature is okay, I said earlier. For me, my metabolism is low, I'm suffering from hypothyroid, I'm still feeling cold. Opposite is hyperthyroidism. Temperature is okay, but still I'm feeling warm, hot, because I'm suffering from hyperthyroidism. In hyperthyroidism also, patients with hyperthyroidism, the blood pressure, they do suffer from, with hyperthyroidism, they do suffer from hypertension. Hypertension is what? What is hypertension? Increase in blood pressure. They diagnosed me with hypothyroidism, and they said, yes, you also have, your blood pressure is not normal, your blood pressure is higher than normal. That means you need to, not only you need to take medication for your thyroid function, you need to take medication to lower the blood pressure also. Because if you don't, I might one day on the floor, because I didn't control my blood pressure, because of the stroke or MI, myocardial infarction. Okay, so hypothyroidism, decreased metabolic rate. Number two, accumulation of hydrophilic mucopolysaccharides substance in the connective tissue that results in myxedema. Please highlight, make it bold, myxedema. Mixed edema is patients those who are suffering from hypothyroidism. They have a peculiar facial appearance. Puffiness of the face. Looks healthy, but they're not healthy. Puffy face. Is it clear? I said, write it down. That mixed edema has a peculiar facial appearance, puffiness of the face. Because mixed edema is low thyroid hormone, decrease in thyroid hormone, is that correct? And they do suffer from bradycardia, low heart rate. Hyperthyroidism, I said hypertension, tachycardia, and hypothyroidism is bradycardia, hypo. Now, please remember the facial features of the mixed edema, which is important. And they do also suffer from these hypothyroid patients, they do have elevated serum cholesterol level. Serum cholesterol. Now, person who is suffering from, please remember, so right now, hypothyroid, these are the features. One of the features which is in adult, we said it is mixed edema. Mixed edema. Facial appearance, I can be diagnosed with if I say my T3, T4 is lower than normal, and I have a peculiar facial appearance and do have no energy in my body, lethargic because of low T3, T4, no metabolism is going on, that's why I'm lethargic, where the heart rate is lower than normal, it's called bradycardia. So we need to take care of these patients. Now, these patients need to be treated with thyroid medication. Most common is we call synthroid. Synthroid. Synthroid is a medication used in hypothyroidism. Synthroid. Synthroid. SYN. THYROID. Synthroid. That means they are produced synthetically in the lab. In the drug company makes it. That's called synthroid. Body is not producing it. It is the lab. Drug company puts that they call synthroid. And the dose start from very low dose and the slow dose. So that is for hypothyroidism. Now, hyperthyroidism, look at them. Now the scene is completely reversed. Increased metabolic rate and oxygen consumption. Metabolism is above normal. Increased use of metabolic fuels. Increased sympathetic nervous system responsiveness. That results in tachycardia, hypertension, and everything going in high end. Hypertension, tachycardia. Feeling hot, temperature is okay, but still I'm sweat. Now, and also lose weight. I have good appetite, but still nothing staying over here. All about the brain. Losing weight, hyperthyroidism. Please remember all those difference between hypo and hyper. It will take a lot of push problem. Of course.
Professor, before you need some clarification, please. For the hypothyroidism, you said it can be treated with synthroid, correct? The hypo.
That's correct.
Bradycardia, right?
And the same trial.
And then the hyper is tachycardia and also loss of weight.
And also?
And loss of weight.
Yeah, because I have appetite. I'm having good appetite, but nothing is staying over here. Diarrhea.
Okay.
But in the hypothyroid, they don't have appetite, but they're increasing body weight, they're gaining body weight, opposite for hypo. Okay, now, Manifestation of hyperthyroidism, how they present. Thyroid storm, restlessness, irritability, anxiety, wakefulness, increased cardiac output. Look at that one. Tachycardia, palpitation, diarrhea, increased appetite. I'm losing weight. That's what I said. Dyspnea, heat intolerance, increased sweat, thin and silky skin and hair, and weight loss. These are the presentation with hyperthyroidism. All are important. Is it clear? Now, there's a condition of hyperthyroidism, I believe in the talk. It's called Graves' disease. Graves' disease. Graves' disease is due to hypersecretion of the thyroid hormone. We call hyperthyroidism. Graves' disease, my eyes are popped up. Eye sign. By looking at the patient's eyes, I can say you are having exophthalmos. Maybe you're suffering from hyperthyroidism. Exophthalmos, eye sign. Now, I was diagnosed with exophthalmos, and they're treating me for those conditions. And all of a sudden, I was having some difficulty in breathing. My temperature is above normal, maybe 99 and up. My vitals all are up. Vitals are all up. Vitals, you folks understand vital, right? Pulse, respiration, blood pressure, all are up. Blood pressure, especially blood pressure, is because already hyperthyroidism, hypertension. My systolic maybe 190 or 200. Diastolic maybe 110, 120. Look at that one. Systolic is 180 or 200. Diastolic is maybe 110, 150, 110. Way above normal. And now, nurse said, as you are, this patient is already known to us as suffering from Graves' disease. This patient with that blood pressure need emergency treatment. We call this patient in hypertensive crisis. What crisis? Hypertensive crisis. If we don't control his or her blood pressure, we're going to lose the patient. Hypertensive crisis. Is it clear? Okay, let me move on now. Now, opposite side, hypothyroidism. Sometimes also, these patients with hyperthyroidism, they are not responding to my medication. The last resort for this hyperthyroidism, remove the thyroid gland. What? Remove the thyroid. Surgical removal of the thyroid gland is the last consideration. I treat with medication, patient not getting help. Now I have the last resort left in my hand. I need to advise that we can remove your thyroid gland. We call thyroidectomy. Thyroidectomy is removal of the thyroid gland because the patient is not responding to my medication. What is the last resort? Thyroidectomy. Now let's move to the hypothyroidism. With hypothyroidism, T3, T4 is way down. But my TSH is shooting crazy. TSH is high. T3, T4 is low. Patient will have maybe mental or physical sluggishness, not feeling well. Patient have myxedema, puffiness of the face, myxedema, puffiness of the face, maybe bradycardia, maybe lethargic. somnolence, not coma, before coma, decreased cardiac output or bradycardia. I already said patient with mixed edema has facial appearance, puffiness, bradycardia. Patient might present with constipation and decreased appetite, increased weight, hypoventilation, cold intolerance. You get this opposite of hyper. And instead of fine silky hair, now it becomes coarse, dry skin and hair. Patient gains weight, even though patient is decreased appetite, not enough eating, but still getting weight. Please remember hypothyroidism. So we can treat with medication. And one of the medication I said synthroid. Is that correct? It's very common. Levothyroxine, levothyroxine, or synthroid. Now, this one I already discussed before. Congenital hypothyroidism by birth defect. Congenital hypothyroidism. Thyroid hormone is essential for normal growth and brain development. I said three things: physical, mental, reproductive. Is that correct? That's over here. The thyroid hormone is essential for normal growth and brain development, and almost half of which occurs during the first 6 months of life. If untreated, congenital hypothyroidism causes mental retardation because not enough T3, T4, my mental development, brain development is not taking place, and also impair my physical growth, short stature, dwarfism. Condition is called what? Look at that one. Somebody's phone is. Please take care from the phone. Thank you. Now, the manifestations of untreated congenital hypothyroidism is referred to as cretinism. Make it bold. Highlight cretinism. It is not bold over here. Highlight it. Cretinism. Oh, dear. That is so important. If we can treat from the very early age, start from first week of my life, we can prevent mental retardation. Physical, we can provide that newborn normal physical growth, later on normal reproductive growth also. Otherwise, these patients are completely sterile. Completely sterile, that means they won't be able to produce anything. Grave disease is one of the conditions of hyperthyroidism. I mentioned, I gave you the scenario. Is that correct? Everybody's okay with that one? And that is my grave disease right now. Grave disease, a state of hyperthyroidism goiter, ophthalmopathy, and dermopathy. In order to remember, I use the drug of God. G-O-D. Goiter, ophthalmopathy, and dermopathy. God will protect with hyperthyroid. Grave disease. Grave disease, there are three features. Goiter, ophthalmopathy, eye will have blurry vision, and thick skin, dermopathy. Now, an autoimmune disorder characterized by abnormal stimulation of the thyroid stimulating gland, abnormal stimulation of the thyroid gland by thyroid stimulating antibodies that can act through normal thyroid hormone receptors. Familial, we do have HLA also, response for Graves' disease, autoimmune, and sometimes runs in family. Familial tendency is also evident for Graves' disease. In most cases, it is autoimmune type, autoimmune. Now, patient with thyroid storm, look at the patient with thyroid storm. That means he or she is having hyperthyroidism. They usually present with high fever, extreme cardiovascular effect, tachycardia, congestive cardiac failure or CCF, and maybe chest pain we call angina. CNS may be agitated, restless, and delirium. These patients do have high mortality rate. But I mentioned about patient with Graves' disease with difficulty in breathing, high temperature, high blood pressure, that is called hypertensive crisis. Patient need an urgent treatment. Is the following true or false? Thyroid storm results in delayed puberty? I don't think so. Thyroid storm is false. Thyroid storm is a severe condition that results in dangerously high temperature. In thyroid storm, temperatures shoot. But in hypertensive crisis, which one is shooting? Blood pressure. In hypertensive crisis, blood pressure is shooting. Look at that one, systolic and diastolic. Systolic in that patient right now sitting in the ER, systolic is 180 to 200. Diastolic varies from 110 to 115 or 120. Normal is 130, has to be below 130 and below 90. Sometimes we do suffer from having blood pressure, hypertension. Sometimes we don't notice.
Professor, I think somebody's in the waiting room.
And doctor said, you are having some blood pressure. Maybe, oh no, I just walked from my car, and that's what reasoning. Okay. Then they might ask you a follow-up visit. And on a certain day you will go, walk slowly, don't use staircase, use elevator to the doctor's office to check your blood pressure, resting blood pressure. If the blood pressure is still high, that means you are suffering from hypertension. Sometimes you don't. And this blood pressure, high blood pressure, we call a silent killer. Silent killer. We don't know it. All of a sudden I'm on the ground. Look at that one. I did never notice that. And that's what they call, this blood pressure is called silent killer, without any symptoms. So.
Professor, they said someone was in the waiting room.
Pardon?
They said someone was in the waiting room.
Someone is in the waiting room.
Pardon?
Someone is in the waiting room.
Oh, wait a minute. Wait. Angie.
I have two questions.
Oh, let me see. Yeah.
So you were talking about the elevator blood pressure, when you go to the doctor and you use the elevator and all that.
Mhm.
What if it's that you don't have any problem with the blood, but the fact that you know you went to the doctor, you kind of, like,
Normally, also that happens, we call white coat,
yes.
which I didn't mention. Sometimes that happens. But you need to take care of that one by seeing the white coat, don't stress on it. Yeah, that was a white coat stress that causes true blood pressure, which I did mention. But before going to the doctor's office, instead of 1 cup of coffee, I had 2 cups of coffee. That shoots out blood pressure. So you need to take care of all those measures. Okay, thank you for Angie. Sometimes I focus over here, sometimes I forget. Okay, now stages of adrenal cortical insufficiency. Now, if you look at that one, adrenal gland, which is sitting on the top of the kidney, the outer zone we call the cortex, inner zone called what? Medulla. Now, that's the normal thing I'm talking about. In order to stimulate my adrenal cortex, we do need the help of what hormones do I need right now to stimulate my adrenal cortex? Pardon?
The posterior.
No.
Cortisol. Cortisol.
Cortisol? No. They will produce cortisol. But how I can stimulate my adrenal cortex? What hormone do we need for stimulation of adrenal cortex?
ACTH.
What?
ACTH.
Adrenal? What?
Adrenal corticosteroid.
Adrenal corticotropic. ACTH you're talking about? No.
Adrenocorticotropic hormone.
Is ACTH. ACTH, which is coming from my anterior pituitary. That's the normal thing. ACTH produced by the anterior pituitary. This anterior ACTH stimulates my adrenal cortex. And this adrenal cortex now, after stimulation, will produce 3 different hormones. 3 different hormones. Mineralocorticoid, which is discussed in the anatomy. Mineralocorticoid, one of the mineralocorticoid we use called aldosterone. Glucocorticoid, we said so many times this morning, cortisol. We also use a trade name we call prednisolone, and androgens, which is my sex hormone. So those are 3 hormones produced from the adrenal cortex after ACTH stimulation. Is it clear? That's the normal thing you have to know. And adrenal medulla needs the help of what? How we can stimulate the adrenal medulla? Who can stimulate my adrenal medulla? It is the sympathetic nervous system. It is sympathetic nerve stimulates my adrenal medulla. Period. Please remember. Adrenal medulla is stimulated by the sympathetic nerve. And this adrenal medulla produces 2 hormones we call catecholamines by the name called epinephrine and norepinephrine. Epinephrine and norepinephrine is secreted, produced by the adrenal medulla. And who is stimulating it? It is my sympathetic nerve. I'm stressed out. My sympathetic nerves are working. And that's the nerve going to stimulate my adrenal medulla, and adrenal medulla is going to produce the same hormone, epinephrine and norepinephrine. Yes or no? Please remember, these are very basic things about these glands. Okay. Now, stages of adrenal cortical insufficiency. Adrenal cortical insufficiency, hypofunction. Primary adrenal cortical insufficiency, bold, the disease name called Addison's disease. Addison's disease is due to lack of adrenocortical hormone secretion. And which hormone? Over here, make a sticky note. With the Addison disease, it is the aldosterone. Which one? Aldosterone is at fault, it's not enough. That's why I'm suffering from Addison disease. And this aldosterone deficiency, what is normal function of aldosterone? If you know the normal function of aldosterone is to reabsorb sodium, reabsorb chloride, excretion of potassium from my kidney. That's the normal job, normal function of aldosterone. I repeat, yes. Normal function of aldosterone is to reabsorb sodium, reabsorb chloride, and excretion of potassium. Is it clear? As a result, if you look at that one, this aldosterone is working on my kidney. On my kidney, we have distal coronary tubule, collecting duct, if you folks remember. Those sides of the kidney, my aldosterone is working on to do this job, reabsorption of sodium, chloride, excretion of potassium. As a result of this function of aldosterone, please remember, after aldosterone done with this function, the blood volume will increase. Blood volume will increase. Everybody is clear with that one? Blood pressure will increase. We'll have to raise the blood pressure. Yes? So, and potassium, the body will lose potassium because potassium was high. We don't want potassium. Potassium is right now the waste product. So in Addison disease, we do suffer from this one. We do suffer from low blood pressure because aldosterone is not there. Now, so highlight the disease called Addison disease. And is it due to what? Aldosterone deficiency. A for Addison, A for aldosterone. Easy to remember. Now, ACTH levels are elevated because of lack of feedback inhibition. Because ACTH is there, and my adrenal cortex is not responding. That's called ACTH level will be elevated because there's no lack of feedback inhibition. Normally, they are controlled by feedback inhibition, negative feedback balance. Secondary, adrenal cortical insufficiency occurs as a result of hypopituitarism. Remember primary, secondary. Occurs as a result of hypopituitarism or because of the pituitary gland has been surgically removed. Because of previous condition, they removed the pituitary gland and now suffering from secondary adrenal cortical insufficiency. Acute adrenal crisis. Life-threatening situation. Is they prescribe me prednisolone for my condition. Normally, all steroid, please remember when you folks work in the clinic, all steroid, when we start, we gradually increase the dose. All steroid, we follow the same principle. We gradually increase the dose of that medicine. One for the very first dose, shoots and then gradually. No. We gradually increase the dose of steroid. And also, we follow the same principle when we withdraw the drug. We gradually withdraw the drug, gradually decrease the dose. If I stop medication right away, this thing will happen. Crisis. Because I shut down the stimulus on the outside all of a sudden by stopping the medication. We don't want to have that thing to happen. Is it clear, folks? That's why all steroid dose is gradually increased, and when we withdraw, gradually decrease. Gradual increase, gradual decrease. Okay. Adrenal insufficiency. Patient might suffer from anorexia, weight loss, fatigue, weakness, gastrointestinal symptoms like nausea, vomiting. Look at that one, arthralgia, abdominal pain, orthostatic hypotension, and hyponatremia. Remember I mentioned about the aldosterone. Aldosterone is not there. My body is getting deficient in hyponatremia. Deficient in sodium. Not only deficient in sodium, also decrease in blood volume, increase in potassium. Okay. Clinical findings is hyperkalemia. Remember the potassium? Potassium is building up because the aldosterone is not there. And we do suffer from hyperpigmentation. And these patients also with Addison disease, I saw that the patient, person 6 months ago with everything normal, after 6 months, a year, John was fair complexion, and I saw John after 1 year, his skin become brown tan. What happened, John? You work outside? Oh, no, I was still working on computer. He started suffering from Addison disease, low aldosterone, that makes his skin brown tan skin. Pigmentation. Is it clear, folks? That is the cause. He is weak, he is on medication, and patient John is suffering from Addison disease, low aldosterone, and also steroid. So, in order to treat this patient, please make a note, we need steroid. Is steroid medication in order to treat this Addison disease or adrenocortical insufficiency. Patients suffering from adrenocortical insufficiency, they need to be treated with steroid. I said steroid. We need to start steroid slowly, gradually increase, and if you want to decrease the dose, or stop the dose, we need to stop gradually. We cannot withdraw all of a sudden. Okay. Okay. Second deficiency, which is already set. Mineralocorticoid, glucocorticoid, and androgen. No change. Mineralocorticoid, aldosterone. These are all coming from adrenal cortex, not medulla. Medulla produces epinephrine, norepinephrine. Adrenal cortex produce these hormones when adrenal cortex is stimulated by ACTH. Okay, so function. Look at the aldosterone, which I mentioned already. I'm just repeating over here. Function is sodium, potassium, and water balance. Is that correct? Which you have already discussed. Retain sodium, reabsorption of sodium, chloride, excretion of potassium. When the sodium is undergoing reabsorption, water is going. Blood volume increases. My blood pressure increases. That's why I say water balance. Glucocorticoid. That is my cortisol. Aid in regulating the metabolic functions of the body and also in controlling the inflammation. Essential for survival in a stress situation. Now, this glucocorticoid also has metabolic function and also has this cortisol has metabolic function and also has anti-inflammatory effect. This cortisol also has anti-inflammatory effects. That means what? They give me medication for like 2 weeks or 3 weeks. They gave with antibiotics and they changed the antibiotics. The doctor said, now I need to start steroid because the antibiotic is not working. I need to prescribe change some antibiotic, but I need to add up with steroid. That's my last resort to control your inflammation, to control your infection. So that because this steroid has anti-inflammatory effect, stop inflammation. Look at that, some inhalers. I'm suffering from asthma. They use bronchodilator along with steroid. Some skin condition, they use normal medication on the top, they add it with steroid. Is it clear? So steroid is the last resort over here. And essential for survival in a stress situation. Look at this steroid. COVID patient in ER, they inject with cortisol. To save the patient with COVID virus, they inject cortisol, steroid, but the drawback of this cortisol, they saved my life, but during the time of treatment, I never had blood sugar. Blood sugar was always normal, but because of steroid, my blood sugar go high. For that, they give insulin to treat and then they follow. But I need to give the steroid to save your life. But what happened to the treatment of cortisol? I never had high blood sugar. I'm suffering from diabetes for the time being. So that needs to be taken care later on. But first thing is they need to save my life with COVID virus. Okay. Is it clear? No? Yes? Okay. Adrenal sex hormone androgens. CV serve mainly as a source of androgen for women. Now, in some cases, in females, this adrenal cortex, they do have tumorous condition of the adrenal cortex. And because the tumorous adrenal cortex, the female having this hormone excessive production. And that androgen in female causes facial hair, the body hair, facial, body hair, and all those hairs are not only the regular hair, they are coarse and dark. The condition of that, in that female, never had those hairs in those part of the body. The condition is called hirsutism. What? Hirsutism. Hirsutism is a condition when the female is suffering from excessive androgen. Is it clear, folks? Excessive androgen causes excessive growth of the body hair, the face, the chest, the back, the arms. They use different types of treatments, and because the fault was because of my adrenal cortex, they could use excessive androgen in female. Male, they do have all hair because of the testosterone, but in female, that androgen causes overproduction of those hair in the female body, and that condition is called what?
Hirsutism.
Hirsutism. Hirsutism. Okay, we do use all those cosmetics, remove those hair, but it's not going to work because the defect is over here. I didn't call it. Oh my goodness. Okay. Action of cortisol. Metabolism sounds similar to my thyroid hormone. Is that correct? If you folks remember, I mentioned that one. Thyroid hormone perform metabolism. I'm not going to change. Overall metabolism, thyroid hormone. Steroid glucocorticoid does the same thing. Glucose metabolism, protein metabolism, fat metabolism. On the top, this cortisol has anti-inflammatory effect. That's what I mentioned that and explained that. I'm not worried about the psychic effect and also not worried about the permissive effect. So please remember the cortisol. We do have, because of the enzyme deficiency that's going on, congenital adrenal hyperplasia, 21 hydroxylase enzyme deficiency in most cases, and 11 beta hydroxylase deficiency also one of the cause. Adrenal cortical insufficiency may be the primary, may be secondary. Is it clear? In secondary adrenal cortical insufficiency, it is my pituitary gland. In the primary, it is my adrenal gland itself. Because we mentioned what is primary, what is secondary. And we do see in acute adrenal crisis, I mentioned if I withdraw my steroid all of a sudden. Please remember, now excessive secretion of cortisol highlight the condition is called Cushing syndrome. Cushing syndrome highlight. It is due to increased production or secretion of cortisol. Maybe pituitary, maybe adrenal, maybe ectopic. Maybe pituitary cause, which results from excessive production of ACTH because of the tumor condition of the pituitary gland. That is secondary. Primary may be adrenal form caused by benign or malignant adrenal tumor, or ectopic form non-pituitary ACH tumor, especially this occurs in small cell carcinoma of the lung. Carcinoma of the lung is in the lung, and that tumor, carcinoma of the lung, the tumor's condition of the lung produce those hormones. Okay, now if you look at that one, everything in overproduction, everything is altered fat metabolism. Muscle becomes weak, muscle wasting start. Highlight purple stripe. In fair skin, this is one of the diagnostic mark. Purple stripe, which in the abdomen, skin of the abdomen. Let me see your skin. Oh, I see those marks. Oh, yeah, doctor, I didn't notice that one. Oh, yes, okay. So this is due to increased production of cortisol. Cushing syndrome. Patient suffering from Cushing syndrome. Osteoporosis, thinning of the bone, derangement of glucose metabolism. If you look at that one, I mentioned that they give cortisol to save my life, my glucose, hyperglycemia I'm suffering from now, maybe temporary diabetes. Hypokalemia, gastric acid secretion, hirsutism. I mentioned earlier, is that correct? Female, they do also have menstrual irregularity. Not only the hairs, we already mentioned about the Addison disease, destruction of the adrenal gland and glucocorticoid insufficiency. These patients with Addison disease, they need to be treated. How we can treat with Addison disease?
Steroid.
Steroid. Look at that one. Deficiency of steroid. Cortisol is not there. So I do need steroid. Adrenal gland and glucocorticoid insufficient results in Addison disease. Otherwise, my blood volume will go down, my blood pressure will go down, and I will go down too. Gone. In contrast, Cushing syndrome. Please remember Cushing syndrome. Sometimes we do need. The face, Cushing syndrome, the face becomes, we call, moon shape. By looking at the face of the patient receiving a glucocorticoid, they need to have the cortisol because of the kidney condition or other condition. But they are suffering, on the other hand, Cushing syndrome. This we call iatrogenic because I describe it for the patient's survival, but patient is suffering from Cushing syndrome. Moon phase, we call deposition of fat in the nape of the neck. So those are the features of Cushing syndrome, patient with Cushing syndrome. Okay. Now this is a different story. We're talking about the pancreas. I need some picture. For the pancreas, please know the normal anatomy. I'm not going to change normal anatomy. What type of gland is it? It is an exocrine gland or endocrine gland? Both. Answer is correct. It is a mixed type of gland. Pancreas is a mixed type of gland. Please remember. And from the exocrine part, pancreas produces various pancreatic juices, various digestive juice coming from the pancreas. And the endocrine part of the pancreas, which are located in the islets of Langerhans, if you could remember, in the islets of Langerhans. Islet of Langerhans means these are small islands of cell. The scientist was Langerhans. He discovered first. He said then, for his respect, they said these are islets of Langerhans. And within those islands, they have 3 different types of cells: alpha cell, beta cell, delta cell. All those cells produce different types of hormone. Please remember. Now, before I go into that part, yes, okay. So, what is they produce hormone in general right now? They produce islets of Langerhans cell. They produce 2 different types of hormone we call insulin and glucagon. Insulin helps to lower the blood glucose after my meal, after my breakfast, whatever. And glucagon helps to raise the blood glucose. I skip my lunch, 3 p.m., 4 p.m., my blood glucose is way down. Pancreas is going to produce glucagon. Glucagon will go straight into which organ? liver and anywhere else? Liver, yes. Muscle, skeletal muscle. Because these two sides, the skeletal muscles and the liver, are the site where my glycogens are stored. Liver glycogen, muscle glycogen. Glucagon will go into my liver and into my muscle, break down glycogen into glucose. And that glucose is released into my blood to raise the blood glucose. Because blood glucose was way down. My brain cell, my neuron need glucose only. Brain cells need glucose only. They don't need amino acid, they don't need fatty acid. They need glucose. Okay, so with that also, so pancreas lower the blood glucose, glucagon raise the blood glucose. Is that correct? I just said. Please make a note. We already mentioned about the growth hormone. We already mentioned about the cortisol. We didn't mention, but I give this little bit highlight about the adrenal medulla, which produces epinephrine, norepinephrine. Is that correct? I mentioned that one. So epinephrine, norepinephrine, especially epinephrine, growth hormone, and glucocorticoid. Glucocorticoid. All these hormones is raising my blood glucose. Everybody understand that one? Not only glucagon, growth hormone, glucocorticoid, and epinephrine. All are working the same fashion, raise the blood glucose. Remember, I went to ER with COVID virus, they gave me shot, cortisol, my blood glucose went up. That's what happened. Growth hormone does the same thing, and epinephrine does the same thing, along with the glucagon. All these are working for what?
Raise
Raise the blood sugar. Okay, folks, make sure you have all those things in your mind before you open your screen for the exam. Okay. We do have type 1 diabetes, type 2 diabetes. Type 1 diabetes, it says over here, type 1 diabetes is the most prevalent form in children. Look at the same thing as like glucocorticoid. Metabolism. Hormone control of glucose, fat, and protein metabolism. Insulin, glucose regulating hormone, like my insulin, glucagon. We have growth hormone, and this, the one I just said, epinephrine I mentioned, glucocorticoid I mentioned, growth hormone I mentioned, they fall under this counter-regulatory hormone. You can open the textbook, you can see these hormones over there. Counter-regulatory hormone. All those hormones raising my blood sugar. Is it clear? Along with glucagon. Glucagon raises my blood sugar. Insulin lowers my blood sugar. Okay. What we so we do use glucose testing, blood test. We do fasting blood glucose tolerance test, random glucose, oral glucose tolerance, capillary whole blood glucose monitoring, and important is right now is hemoglobin A1C. Hemoglobin A1C to diagnose the diabetes. And we do, of course, check sugar in urine also. large proportion of the population, of US population, they're suffering from pre-diabetes. Pre-diabetes. If they don't control their sugar, they end up in diabetes. Is it clear? Large proportion of the population, of US population, they're suffering from pre-diabetes. Pre-diabetes. If they don't control their diet, end up with diabetes. And if one start the diabetes, it's a lifelong commitment. Everything, your lifestyle, your food, you have to stick with that one if you want to survive. Is it clear? That is okay. So clinical manipulation treatment, I mentioned that one, type 2 diabetes. Over here, in type 2 diabetes, insulins are okay. Insulins are produced, but the receptors of the body cell where insulin used to work, those receptors are not responding. In type 2 diabetes, receptors are at fault. But in type 1 diabetes, insulin is not there. Insulin is not there in type 1. So we need to treat type 1 with insulin right away. Receptors are okay, but insulin is not there. In type 2 diabetes, we have insulin, but my receptors are not there. So we need to give medication to kick in those receptors. We use oral tablet. Metformin is very common. Metformin, oral form of tablet. Okay, so we do have, female do suffer from, during pregnancy, they do suffer from, gestational diabetes, but after pregnancy, those females need to go under follow-up treatment. If the diabetes is still there or they are in good shape, diabetes control or not. So patient need to be in follow-up treatment. Okay. Complication. Diabetic ketoacidosis and hypoglycemia. These are very common. We do have hyperosmolar, hyperglycemic state. These are the effect of treatment. Because homology effect, and sometimes I had insulin in the evening, the night before, the day before, and next day morning, my blood sugar is very high. And then later on, it go back to normal. So Dawn's phenomenon says, in the early morning, the glucagon kicks in, and that high glucagon raises my blood sugar. That doesn't mean I have diabetes. Is it clear? But I have diabetes not in the early morning. I had diabetes throughout the day. But in the early morning, I have my sugar went crazy, high. This is the normal. That's what this called the Dawn. He theorized. He said this is the thing because in the early morning, glucagon kicks in. That makes my blood sugar high. That doesn't mean you didn't have your insulin didn't work. Insulin is working, but early morning because the glucagon sugar is high. Sometimes they say, "Oh, I need to raise my dose because my sugar is so high in the morning." Doctor, can you help me out? Doctor said, "No, you are fine, but this is the normal phenomenon." Is it clear? This is a complication of the diabetes in the form of microvascular complications. Macrovascular diabetic foot ulcers, and in the form of infections. Infections can occur. Infection occurs at the injection site. Infection occurs at the injection site. Repeated injection of insulin cause infection. They do suffer from patient with diabetes, they do suffer from nephropathy, retinopathy, eyes, or cataract. Most common, cataract is common. Food ulcer, because the sugar in the wound, is the bacteria love those sugar for their survival. That's why they have infection. And because of the neuropathy, I'm hitting the ball, the hard surface, I'm not getting pain. My skin gets cracked, the wound becomes infected because of sugar, bacteria multiply. Sometimes times comes, sometimes amputation. No choice left. So, folks, let's have a break. You do need break with so many hormones. Okay, folks, last returning time is 12 noon, because within that 1 hour, I need to take care of chapter 48 and 49. 12 noon is the returning time. Zoom, 12 noon is the returning time. You folks understand? 12 noon. Okay. So we'll be coming back at 12 noon. We'll discuss chapter 48 and 49. Thank you.
I
I'm Roger.
Oh, you see the book?